Thank you all so much for joining us today. On behalf of the Center for Occupational and Environmental Health, I would like to welcome you to our webinar, Severe Silicosis and Engineered Stone Fabrication Workers, U.S. Perspectives, with Dr. Robert Harrison. A few housekeeping items first. You will be muted during this presentation. If you would like to ask a question, please enter it into the online chat or Q&A. We will save time at the end of this presentation to address all questions. When you exit the webinar, a link to our evaluation will become available in your browser. You will also receive a follow-up email with a link to the evaluation tomorrow on December 12th. Attendees who have participated in the complete live webinar today with an attentiveness score of 85% or higher will be eligible to receive a certificate of completion. Once you complete the online evaluation, you will receive your certificate as a PDF via email within 1 week. Attentiveness scores are calculated by our webinar provider and are based on continuous engagement throughout the presentation. Some tips on how to keep that attentiveness score high, above 85%, is to join the webinar on time and remain logged in for the entirety of the presentation. Do not use your device to navigate away from the presentation. If you are not clicked into Zoom as your primary selected window, your attentiveness level will lower. Checking emails or doing other work on your device continuously lowers your attentiveness score, so try to keep necessary distractions brief during the presentation. This presentation is being recorded and will be made available on the Center for Occupational and Environmental Health YouTube page and on our website, coeh.berkeley.edu. At this time, we're pleased to welcome our presenter, Dr. Robert Harrison. Dr. Harrison is a medical officer with the California Department of Public Health and clinical professor at the University of California, San Francisco in the Division of Occupational and Environmental Medicine. He established the UCSF Occupational Health Services in 1984, where he has diagnosed and treated thousands of work and environmental injuries and illnesses. He has designed and implemented numerous medical monitoring programs for workplace exposures and has consulted widely with employers, healthcare professionals, and labor organizations on the prevention of work-related injuries and illnesses. Dr. Harrison has led many work and environmental investigations of disease outbreaks. He has served as a technical and scientific consultant to federal OSHA, CDC, and NIOSH, and was a member of the California Occupational Safety and Health Standards Board. He is currently the director of the NIOSH-funded Occupational Health Internship Program and associate director of UCSF Occupational and Environmental Medicine Residency Program. His research interests include the collection and analysis of California and national data on the incidence of work-related injuries and illnesses. Dr. Harrison has authored or co-authored more than 50 peer-reviewed journal articles and more than 40 book chapters, contributed articles and letters to the editor. He is the co-editor of the most recent edition of the textbook, Occupational and Environmental Medicine. Thank you so much for joining us.
Thank you, and welcome all to the presentation here today. I'm so glad that you can join us and are interested in and can learn about and can help with our ongoing research and investigation on silicosis in engineered stone fabrication workers. This is very much a collaborative effort, and you can see that Dr. Cecile Rose from National Jewish at the University of Colorado, Dr. Amy Heinzerling with the California Department of Public Health, Ketki Patel, a physician with the Texas Department of State Health Services, and Dr. Carlin Sack at the University of Washington have contributed and collaborated with this investigation. Dr. Amy Heinzerling with the California Department of Public Health has been the lead for the investigation in California, and she's bolded in red for that reason, for me to acknowledge her contribution and efforts, and also for the terrific slide pack that you're going to see today. I wish I could take credit for these slides, but full credit goes to Amy Heinzerling for the content that you're going to see today on the slides. You can read in detail much of what I'm going to present today in the Morbidity and Mortality Weekly Report at the end of September of this year. And this was a report of 18 cases of severe silicosis in engineered stone fabrication workers in 4 states. The term engineered stone might not be familiar to everybody listening on the call. An equivalent term is often called quartz product or artificial stone. So if you hear those terms during the course of the call or you read more about this, they describe the identical product. Let me take you through the chronology of how this has unfolded and bring you up to date with where we are today. In January of 2019, one of the state epidemiologists with whom I work, Jennifer Flattery, sent me an email, and I wanted to give you some sense of how a public health investigation unfolds, more or less in real time. Some may think that there are sophisticated, ongoing computer systems, large databases by which we know about and can track occupational disease cases or outbreaks in real time. In fact, this is often how it works. It's an inquisitive epidemiologist or an alert healthcare provider, an email, a phone call. Someone years ago used to say that all politics is local. I like to think that all public health is local. And here's an example of a local public health alert. This was an email from a collaborator in my office, works 15 feet away from my desk, and Jennifer Flattery found in the 2017 OSHPD data, we call it OSHPD, but this is a state database. When an individual is hospitalized anywhere in California into the 400 plus acute care hospitals, and they're discharged, their discharge diagnoses receive an ICD code, a diagnostic code, and that makes its way into a statewide computer database. Jennifer Flattery made an inquiry to that database for all primary diagnoses of silicosis with hospital discharge. And she located a 37-year-old man with a diagnosis of silicosis, and the hospital discharge records just said he was cutting stone. And we then were going to take a look at his medical records and do an investigation. The reason why we triggered this investigation, because a 37-year-old with silicosis is very unusual. That would indicate probably a relatively rapid onset of disease occurring over the 5 to at most 15-year period, given the typical date of hire of someone. And that would be pretty unusual to see in such a young man. We then triggered an investigation, obtained the medical records, started to perform a series of interviews. And we learned that this index case, this individual who had been discharged from the hospital, first began working in 2004 at a stone countertop fabrication shop. Let me stop and explain what a stone countertop fabrication shop is. If I want to renovate or redo my kitchen, I want to update, modernize my outdated kitchen, or I'm moving into a new construction townhouse and I want to make a selection of kitchen countertop. I will often go into either a big box store or a marble and tile showroom, and I'll see a range of different products. 20 years ago, I probably would have seen mostly granite or natural quarried stone. In 2019, probably 80% of what I'm going to see is what's called engineer or artificial stone. They're manufactured by a number of international brands, and they come in virtually an unlimited variety and different palette of colors. And you can see an example here on the slide of one countertop. This actually looks like it may, I'm not sure that's a kitchen, it could be a bathroom. It has white and has different colored texture or marble appearance that looks like real stone, but it's actually made out of a composite of silica sand combined with a polyester resin binder, to which various pigments and other additives combine to give that different color variation. When I purchased that product at the retail level, my contractor, who is in charge of designing my kitchen or doing the actual installation, will typically go to a subcontractor in a stone fabrication shop. Will bring the stone fabrication contractor a template of my kitchen counter, and then the workers in that shop will cut and grind and polish the artificial stone countertop to the exact template or shape that then is brought by the contractor and placed in my kitchen or my bathroom. You can see in the other picture on this slide that somebody is using a small handsaw, and he's cutting an edge of one of these slabs to the shape that is desired for installation. These slabs are produced worldwide, and they're typically on the order of about 6 feet by 3.5 feet wide. They weigh 500 to 600 pounds. When they're imported, they're stored either directly at the countertop fabrication shop, or more commonly in a warehouse sold by a middle wholesaler who imports a variety of different products and then will send what's needed to the fabrication shop for customization. The index case had begun work first in Los Angeles and then in the San Francisco Bay Area at one of these stone countertop fabrication shops. He was initially a laborer and then became a polisher and a fabricator. He was cutting, grinding, polishing artificial stone. By 2013, about 9 years later, he presented with progressive shortness of breath and initially was examined by his primary care provider and referred to a rheumatologist because he had a variety of systemic autoimmune type complaints. He was initially diagnosed with scleroderma or systemic sclerosis and placed on immunosuppressive medication. Within 6 to 12 months, he was referred to his pulmonary specialist for abnormal chest x-ray findings and diagnosed with silicosis. Over the next 3 to 4 years, his lung symptoms gradually worsened. He had progressive loss of pulmonary function, a decline in total lung capacity to about 40 to 50%. In early 2018, he was referred for evaluation for lung transplantation, but unfortunately had developed secondary medical problems, a great deal of weight loss, and was determined to be ineligible for lung transplantation. In September of 2018, subsequent to the hospital discharge record that we had detected in 2017, he unfortunately died with a diagnosis of accelerated silicosis. So let me remind you what the spectrum of silicosis is. I just used the term accelerated silicosis. There are 3 major forms of silicosis. The first, which is probably the most common and the one that most of us probably would be most familiar with, is chronic, or also called simple silicosis. The worker typically has relatively lower levels of silica dust exposure with very slow, insidious onset of symptoms, often over the course of a decade or more, presenting with interstitial lung disease, 15, 20, 25 years, either after exposure onset or of lengthy duration of silica dust exposure. On the other end of the spectrum is acute silicosis, rapid onset of massive progressive fibrosis, often over the course of a few months, associated with massive exposure to silica dust. In the middle is accelerated silicosis, which is what our index case had. Typically, exposure duration a year, 3, 5 years, with a relatively rapid onset of disease that can present with coalescing nodules, alveolar proteinosis, and a relatively rapid downhill progressive inexorable course with loss of lung function and capacity, sometimes resulting in the need for lung transplant. Exposures to silica dust are well characterized, well known. Here are some of the occupations associated with silica dust exposure. Coal mining, the most recent outbreak of severe silicosis, many cases of progressive massive fibrosis in the last 3 to 5 years occurring in Appalachia as the coal seams become more difficult to extract and are associated with higher content of silica-containing rock. That's been published by NIOSH and others in several articles in the last 3 years. Hydraulic fracturing, relatively new source of silica dust exposure. This is due to the use of silica sand in fracking fluids. Sand and gravel mining and construction and quarrying, also very well recognized source of silica dust exposure. In fact, the hazards of silica dust have been known for many centuries. This slide dates it from the 1700s. Bernardino Ramazzini, often considered the initial physician founder of the modern field of occupational medicine, describes silicosis in stone cutters. In the 1930s, there was a disaster at Hawks Nest Tunnel in West Virginia. Several hundred miners died of acute silicosis, blasting a tunnel for the railroad through this rock that contained heavy amounts of silica dust. And it led to landmark legislation. Francis Perkins, one of the first secretaries of labor, passed legislation to protect workers against silica dust. Congressional hearings were held in the 1930s. So we've certainly known from South Africa and England in published reports from other parts of the world, Turkish denim manufacturers where silica is used to make wash denim from Turkey. These reports have been published over the ensuing 100 years. But what are we facing now? Why is this new? In 1975, Marcello Toncelli, who was an Italian engineer, patented a new process called vibrocompression under vacuum. In this process, a mixture of fragmented stone or silica dust, and it's about 93% silica dust, is mixed with a polyester resin binder in the manufacturing facilities of engineered stone slabs. The polyester resin is also mixed with a relatively high percentage of styrene monomer, as well as phthalic anhydride. And that is vibrated and compressed under a vacuum process by which the silica particles are uniformly coated with polyester resin. That's heated and then cooled and forms a very hard, resistant surface that is then polished to a fine sheen and sold as large finished slabs. Those slabs are typically placed in containers and shipped around the world for export into different countries. This company is called Breton. So you can see that Marcello Toncelli was actually the founder of that company. Breton initially began to sell artificial stone under a couple of different brand names, but has primarily licensed this patented technology along with the production machinery to over 60 manufacturers worldwide. The first manufacturer that obtained, one of the first manufacturers that obtained the patented process was Caesar stone in 1987. And Caesar stone probably is one of the brand names that may be most familiar to many of us in the United States because it was one of the first artificial stone products to be imported and to be distributed nationally. And in fact, one of the first locations for Caesar stones sales was in California in the early 2000s. Caesar stone is produced on a kibbutz in Israel. You can see a picture of the production facility adjacent to the Mediterranean. And in 2012, the first published reports of severe silicosis among fabricators was published in Chess by Mordecai Kramer and other co-authors, including my colleague, Dr. Paul Blanc. They reported 25 cases of severe silicosis, including many that had been evaluated and undergone lung transplantation. In that report, the first case was initially seen by those researchers in 1997. I mentioned that here on the slide because you can see that Caesar stone began production in 1987, and within 5 years had about 95% of the artificial stone market in Israel, not surprising as they were an Israeli-founded company. And the first case first presented to the physicians in 1997. That suggests a relatively rapid onset of lung disease that was first observed in Israel. Breton then sells the patent to another major engineered stone company called Cosentino. They began production in 1990 in Almeria, Spain. Cosentino has 4 to 5 production facilities. You can see a slide there. Gives you some sense of how large these facilities are. They're producing hundreds of thousands of square feet of engineered stone per year. By 2010, Martinez and co-authors first reported cases. I think they had 3 cases in the 2010 publication. The first case had the onset of exposures 17 years earlier, which you can see coincides pretty nicely with the production by Cosentino of their products in Spain. Cosentino sells under the brand name Silestone, which is also familiar to many of us in the United States, particularly if you go into some of the major large box stores. So by 2019, at last count, there are over 700 cases worldwide that have been reported of silicosis, many cases quite severe. You can see the Spanish reports, the Israeli reports. They now number over 300 in each location. In August, there was a paper published by a Shanghai pulmonary physician of over 100 cases, located in in a medium-sized city in China. And then most recently in Australia, this slide says 98 cases. I think they may be over 150 cases now. And I believe there are about 25 cases of progressive massive fibrosis. Why Australia? Australia sells 2 major products, Caesar stone and another product called Vica stone. Vica stone is produced under the same Breton process at a production facility outside of Hanoi, Vietnam, and then is exported for sale in the Australian market. And then finally, you can see the 18 cases, including the 2 deaths that we reported in the United States. Why is engineered stone an emerging threat? This slide, I think, sums it up pretty nicely. In the United States, quartz service imports have increased 600% over the last decade. In addition to Caesar stone and Silestone, relatively common brand names, Cambria is another product that's sold widely throughout the United States. Cambria has a production facility in Minnesota where they're headquartered, and in a couple of other locations around the United States. Cambria is the only US-owned manufacturer of engineered stone products. So we have the index case that I described to you of progressive massive fibrosis, accelerated silicosis, resulting in death in 2018. In the course of our investigation of the index case, we were able to interview a relative, and he reported to us that another individual who worked at the same company had also died of respiratory failure. We were able to obtain the medical records and the result of the autopsy from the Alameda County Sheriff's Office. The autopsy report unfortunately did not include microscopic analysis of lung tissue, but with permission from the father of this individual, we obtained the sample of lung tissue that had been preserved at the time of autopsy. You can see there a picture of Ryan Guinness, one of the preventive medicine residents from Kaiser, and Ryan and Josh Batoko from our occupational medicine program were able to retrieve the lung tissue. You can see Ryan taking a look at the formalin preserved tissue. That was brought to Dr. Kirk Jones, a pulmonary pathologist at UC San Francisco, and there's a photomicrograph of alveolar proteinosis, which is a, I don't show you another slide, but there's a photomicrograph that clearly shows birefringent particles of silica in this individual's lung tissue as well. Alveolar proteinosis has been observed in many other cases of accelerated silicosis. It's a proteinaceous fluid. You can see the large pinkus globules that are in the air sacs in this photomicrograph. I also wanted to point out a little snapshot of the permission from the father, and those are his initials. He's initialing the consent because he is from El Salvador and does not read or write in English. The two individuals who died from this one facility were also not able to read or write English. And that highlights the characteristic of the California workforce. Most immigrants, most Spanish-speaking from El Salvador, Guatemala, and Mexico. That creates challenges in outreach, health communication, and in inviting participation in medical monitoring programs. So in addition to the two fatalities identified from this one employer, in the course of our follow-up investigation, we found a third case who's alive, who had also been diagnosed with silicosis by another healthcare provider in the Bay Area that had not previously been reported, had not been hospitalized, so we didn't detect in outpatient hospital discharge records. So now we have the three cases, two fatalities, and one diagnosed case. As a result of follow-up investigation, this particular employer undertook screening, that is medical examination, of the other employees at this location, both in Southern and Northern California, and we identified three other workers with CT-confirmed cases of silicosis. So now we have 7 from this one employer. I'm sorry, 6. Can't count. 6 cases from this one employer. Doing simple math, if there are 6 silicosis cases among the workers screened at this one particular employer, that's a 12.5% prevalence of silicosis. Keep that figure in mind for a minute. All were Hispanic men, and 5 of the 6 were less than 40 years of age at the time of their diagnosis. Relatively young individuals. In the course of our investigation, almost simultaneously, within a 6-month window, we learned about other cases that had been detected in Texas, Colorado, and Washington. Of interest, each of those cases of silicosis were identified through different mechanisms. In the case of Washington State, the one case was detected through the workers' compensation system. That worker had filed a workers' compensation claim, was getting compensated, was undergoing treatment at a tertiary medical center in Washington State, and colleagues at the Washington State Department of Labor and Industries had been aware of that one case, but had not connected the dots to literally or figuratively to the other cases that are shown on the map. In the case of Colorado, Dr. Cecile Rose had done a retrospective review of her own consultation practice at National Jewish and had identified 7 cases with confirmed diagnoses of silicosis, all working in stone fabrication shops. And then in Texas, 4 cases were identified from one large stone fabrication facility where in addition to the manufacturing side, there was a large fabrication shop that was cutting these slabs to the specific sizes and shapes needed by the customers. So we have a total of 18 cases detected within about a year period, including 2 fatalities. So the question came up, well, how many cases are there in the United States? All of the cases from the 4 states were detected by various mechanisms, and the collaborators who produced the report in the MMWR at the end of September were in touch with each other through networking and collaborations through relatively informal means, but not through any national case detection system. So that raises the question, is this just the tip of the iceberg? So here are the 18 cases. If you take the prevalence of silicosis in Australia, the state of Queensland, where the outbreak of silicosis has occurred, is offering all stonemasons, which is the term in Australia used for stone fabrication worker, stonemasons free medical examinations paid for by the compensation system in Queensland, Australia. And over 1,000 workers have come forward for comprehensive silica medical examinations, including chest x-ray, B-read, spirometry, and in many cases, full pulmonary function studies and chest CT scans. The prevalence of confirmed silicosis in Australia with over 1,000 participants is about 12%. And you will recall from our small outbreak investigation in one employer, we have a prevalence of about the same. So if we were to take 12%, assuming that Australia is the same in terms of workforce demographics, products, manufacturing techniques, and silica dust levels in the fabrication workshops to that in the United States, and estimate that there are about 8,700 stone fabrication establishments in the United States. That's based on publicly available employment data, with over 96,000 workers employed in this industry. That corresponds to over 11,000 workers with silicosis who work in these establishments in the United States. So the question arises is, if we published 18 cases, where are all the others? And I would suggest some answers to you. So we know that silicosis is preventable and that there's a comprehensive Silica Standard that was passed in 2016. That standard requires that employers control silica dust exposure below a newly reset PEL, which is 50 micrograms per meter cubed, with an action level of half of that, or 0.25 milligrams per meter cubed. The silica standard requires exposure controls and monitoring of silica dust levels. You can see in this particular photo that the cutting here is done with a lot of water or using wet methods with local exhaust ventilation and appropriate respiratory protection. Looks like that's a full face respirator with dust cartridges. And then finally, it requires medical surveillance, which is triggered by the use of a respirator and the exceedance of the action level for more than 30 days per year. That medical surveillance requires a history and physical examination focused on cardiac and respiratory problems, a chest x-ray with a B read according to the ILO definition for pneumoconiosis, so that's a standardized B read, and requires spirometry performed by a NIOSH certified spirometry technician. But there are limitations of the standard-based medical monitoring and surveillance program. First of all, as I mentioned, it relies on employers performing exposure monitoring. And we know that many employers, particularly those that work in small businesses, and many of these shops, these fabrication shops, are relatively small. They could range from 2 to 3 employees in a rented garage space to 25 or 30 employees in a larger space in a warehouse. Most of them are on the smaller end, and because they're small employers and they may not be familiar with either the OSHA standard, what exposure monitoring entails, they may not be able to afford the expense of hiring an industrial hygienist. They may not be familiar with the resources available to them, either from their workers' compensation insurance company or from COEH consultation. So without the exposure monitoring to trigger the requirement for medical monitoring, that medical monitoring and testing may not occur. There's also relatively limited sensitivity of a chest x-ray. And this is a point that I would emphasize that's come out of Australia fairly recently in the last 3 to 4 months. There's been publications both in the peer review literature and a recent set of guidelines from our Australian colleagues that about 43% of confirmed silicosis cases in Australia were read as chest x-ray negative. That is normal chest film, normal B read, but an abnormal CT scan consistent with pneumoconiosis. So the chest CT is more sensitive than the chest x-ray for the diagnosis of silicosis. The federal OSHA silica standard requires a chest x-ray with B read without a heightened awareness on the part of healthcare providers who are performing medical monitoring, if that is performed in relation to stone fabrication work. If that individual is not referred for further pulmonary or occupational medicine workup, that includes a chest CT, that person may have a normal chest x-ray, would not be diagnosed with silicosis. The employer in this particular outbreak that I described to you did recently receive a major financial penalty after a COEH inspection, almost $900,000, which to my knowledge constitute the largest U.S. penalty in this particular industry. That's currently under appeal from what I understand. So we have some challenges. I've already mentioned employer compliance with the comprehensive federal OSHA silica standard. The second, which I think is implicit when I mention the consent form from the father, these are what I would term vulnerable or precarious workers. Many of them, at least in California, are immigrants to the United States. The index case that I mentioned to you had taken this job for what his family described as better pay. And that started about $10 per hour, and I think he worked up to about $15 or $20 per hour. His job did come with benefits and did have access initially to the healthcare system. But many workers, particularly in small businesses, do not have health insurance. They may be covered or not by the Affordable Care Act, the equivalent of the Medicaid system in California, may initially seek care through their primary care provider or federally qualified health centers. The providers in those contexts may not be as aware of silicosis or take an occupational history during the initial encounter, are probably less familiar with the workers' compensation system. The cases, as I pointed out to you in the index case, may initially be suspected with autoimmune disease until an accurate occupational history is obtained. And then finally, although a workers' compensation claim may be appropriate, some precarious workers may not want to file a workers' compensation claim for fear of harassment or retribution, particularly in a small employer type of situation. Once a diagnosis of silicosis is made, the healthcare provider may restrict that employee from further silica dust exposure. And in a small shop, there's probably no other job that a fabrication worker could be assigned to. And after a period of temporary disability, if they file a workers' compensation claim, and that runs for a year or so, they would no longer be able to get any temporary disability compensation. If the case is litigated under workers' compensation, which many of these cases have been in my experience, the permanent disability award is not enough to replace the wages, and the diagnosed worker has gone from a relatively well-paying job to other employment with lower pay. And so, long story short, they may be reluctant to come forth and undergo a silica medical exam if there's a fear of being diagnosed with silicosis. And then finally, I mentioned that there are gaps in the screening protocols and procedures. Although the employer is responsible under the Silicosis Standard in paying for a medical examination, the approximate price of that medical examination runs between $400 and $500, depending on the healthcare provider. Of course, that entails a medical encounter, a chest X-ray, B-read, spirometry, and then some required administrative follow-up. Although $400 or $500 may not sound like a lot to many of us on the call, to a small employer with 3 or 4 employees who need medical testing, a $2,000 or $3,000 payment to a local healthcare provider or clinic is a lot of money. And so I leave you with a couple of final questions. First of all, would there be a benefit to a national screening program for stone fabrication workers? There's a model, which is the Black Lung program that was passed by Congress in the early 1970s that provides free medical examination to all eligible coal miners. And the protocol is actually very similar to what's required under the federal OSHA silica standard: chest X-ray, B-read, spirometry, evaluation by a knowledgeable healthcare provider, referral for specialist workup. And that's set on a national level, although it's primarily focused on underground miners in Appalachia. It offers some sort of model for thinking about what we could do on a national level to deal with what I think is a hidden epidemic. The corporate responsibility, what I would call the product stewardship, I think is also another important question. Here's a partial list of the engineered stone manufacturers. You can see on this list, I've already mentioned Breton from Italy, Caesar Stone from Israel, Cambria in the United States, Vica Stone from Vietnam. But you can see a very long list of other companies that produce globally. On this list, I don't have Chinese manufacturers. Within the last 5 to 10 years, about 60% of the global market for engineered stone has been taken by Chinese manufacturers. The Breton process was engineered by Chinese producers, and I think there's over 100 engineered stone manufacturing facilities in China. They have begun to export to the United States. The U.S. International Trade Commission ruled last year that the Chinese were subsidizing engineered stone products and selling them at unfairly lower prices in the United States, and have placed a 300% tariff last year on Chinese engineered stone products. They're still available for sale in the United States, although not at such a low price. There has been a new complaint filed with the U.S. International Trade Commission in regard to similar unfair trade practices alleged from Turkish and Indian manufacturers. So I think we're going to be seeing the emergence of this disease in all countries where engineered stone products become widely available and sold. As the economy improves the livelihoods and a greater proportion of the world enters the middle class income bracket, as they begin to build or renovate their kitchens, this is going to be the product of choice. And there are going to be workers likely in small dusty workshops around the world who will develop silicosis. So with that, I just would want to mention that since the 18 cases have been published, we've identified 2 additional cases since September. One gentleman who has severe accelerated silicosis and is undergoing workup and evaluation, and may be facing eventually the need for lung transplantation. And another individual who died in 2014, who was diagnosed with silica proteinosis in 2010, and who died 5 years later at the age of 45. So with that, I would like to thank all my collaborators and colleagues. This truly takes a collective effort to identify, highlight, publish these cases, bring it to the attention of the healthcare provider community, to work collaboratively with employers, worker organizations, manufacturers, in the hopes that we can diagnose the existing disease among our workers at an early stage, where hopefully we can reduce their ongoing silica dust exposure and then put an end to what may be a future epidemic. So thank you very much, and I'll turn it back to you, Michelle. I think you're going to field some questions.
Wonderful. Thank you so much for that presentation. This time we are accepting questions. You can either enter those questions into the webinar chat box or also into the online Q&A. We do have some questions that have already come in. The first, how does the disease incidence in fabricated stone compare with granite or other non-engineered products?
That's a great question, and I don't have a concise answer for you. Silicosis has certainly been identified, published among granite cutters probably for 100 years. There's a fascinating report of silicosis in Vermont granite cutters published by the U.S. Public Health Service in 1929. And if anybody wants to do some amazing historical reading, you can see that there were hundreds of cases in that industry. There's also been silicosis in granite quarriers and cutters from Southeast Asia that have been published. Granite contains about 50 to 60% silica. And so there's no question that silica dust levels can be excessive even when cutting granite. Dr. Margaret Phillips in Oklahoma has published some papers about 5 or 6 years ago, and I can again supply anybody who's interested with those references. And there's silica overexposures even with granite manufacture. However, that being said, I think the experience of the physicians around the world who have been diagnosing and reporting cases from artificial stone suggests that there's something more aggressive, either because of the height of the silica dust levels that are seen because of the silica content, or the combination with polyester resin that may be more immunogenic and may be combined with the fibrogenic effects of the silica dust because of the polyester resin component. So I think the bottom line is that we need more research to answer that question definitively. My own personal view is that the characteristics of the cases that we've been seeing thus far, particularly among young workers with the onset of silicosis within a few years, and I think the earliest cases have been seen in Australia with as little as 1 year of exposure, is something different than what we were seeing with just granite.
Thank you. We do have some more questions. Another question is, were the negative reported CXRs from Australia read by B readers? Yes.
So all the chest films in Australia have had B reads. Again, I can post some information. Michelle, we can talk offline. There's a very good report that just came out from the Australian radiology community, their organization there, that reports on this data, and that includes chest x-ray with B reads and HRCT scanning. So they've done an analysis of the relative sensitivity of those. And yeah, they were all B read.
Great, thank you. We have another question. Why are we seeing accelerated silicosis rather than chronic with these products?
Again, it's another really great question. I think it's the level of silica dust exposure. I don't have analytic data upon which I can quote you. I can just tell you that anecdotally, in the employer who was involved in the index cases, the description that we published had, and this you can read about in the MMWR report, about 10 years ago, had silica dust levels that were 20 times in excess of the current OSHA silica PEL at that time, which was 100. It's since dropped to 50 micrograms. But in 2009, I think it was, they were over 20 times the silica PEL. The workers will tell me that when they cut engineered stone, there's something a little bit different about the dust to them that's generated. It's a very fine dust that probably represents the uniform characteristics of the engineered stone. Remember, it's mixed and with polyester resin in a uniform mixture that's then vibrocompacted under vacuum. And then when it's cut, they will describe the clouds of silica dust that are in the air. We don't have good data on relative particle distribution size in the cutting of artificial stone versus granite, which I think would be interesting to do some more careful industrial hygiene data measurements on this. I think those are the factors that are leading to this picture of accelerated rather than chronic silicosis among these workers.
Great, thank you. And that actually gets to another question that was asked, if there are any known health concerns regarding larger silica dust particles, i.e. greater than PM10 versus smaller silica dust.
Not that I know of. I think we're really talking about the inhalable fraction, the respirable fraction of PM 2.5.
Thank you.
So I'm not aware that the greater than 10 particulate dust levels.
Okay, thank you. We also have a couple more questions here. Was air monitoring or other evaluation performed at the suspect company prior to the worker's death?
Yes. Again, I just mentioned the historical air monitoring that was done at a point. Let me see. I think that was done. I think we published it in the MMWR. I think it was 2000. It was either 2009 or 2011. Have to double check in the MMWR. But yes, certainly it was done during the time that the index case was and the other case was working there. Wow. And they were greatly in excess of the PEL.
And another question regarding the effectiveness of water controls, specifically water curtains. Is that something you can speak to?
Probably not.
Okay.
I mean, water is definitely a recommended strategy, but I don't have an opinion or know. If we had an industrial hygienist on the phone with me who could speak to that, they would be the person to best answer that question. There's a NIOSH OSHA hazard alert out specific for this industry that may have some information. There's an excellent researcher at NIOSH who has been investigating control technologies, and again, I can give the caller a link, the questioner a link to that information, and to give them more information of the expert at NIOSH who would know.
Great, thank you. We also have a note and a question. The note is, or comment is that the baseline exam also includes a TB test.
Yes, thank you very much. I neglected to say that. Absolutely right.
And then a question, has Cal OSHA, OSHA, or NIOSH provided any oversight of the medical surveillance examination process to ensure it's being done correctly? And currently none of these entities do any medical quality assurance.
So that's another really good question. So the OSHA standard requires chest X-ray and B-read, of course, NIOSH certified spirometry. So to that extent, there is a kind of a medical QC built into the standard itself. But I think the question probably was really addressing is when workers are referred for that medical testing, let's say, with or without being triggered by the OSHA Silica Standard, what sort of QA/QC processes are in place? Let's say similar to the black lung screening program, which does have that built in. You're a black lung clinic. If you're certified and you're basically vetted by NIOSH to participate in that federally funded program, I am not aware of any similar mechanism in place for medical screening and monitoring in compliance with the Silica Standard. I think it's a very good lengthy discussion about how we ensure generally in the field of occupational medicine or occupational health QA/QC, so that we can ensure that when employees are undergoing medical monitoring, that they're getting it according to the best standards of practice and care. I'm not aware that there's any organization that certifies medical monitoring at this point in time.
Wonderful, thank you so much. We do have another comment regarding the water controls. One of our learners wanted to let us know that from reviewing the preamble from the OSHA Silica Standard, water is effective for controlling exposures depending on the circumstances. You should review that federal OSHA standard and related references for discussion of specific processes and controls.
Great. I knew we were going to have somebody who knew the answer on the phone. Thank you.
And let's see, we also have another comment. There is applied research at the University of Oklahoma looking at the best methods for traditional and non-traditional controls and sampling results. For example, sheet flow wetting with LEV and water jet cutting.
Great. Great.
Great.
Yeah, thank you. I think I was referring to Dr. Margaret Phillips and her group there at the University of Oklahoma. Yeah, they really have some excellent information. I think they've published some recent studies.
Great. Well, thank you all so much for joining us today. Yes, the copies of the slides are available. They're actually going to be built into the evaluation. So once you complete your online evaluation, you will be able to download a PDF copy of the slides from today's presentation. Thank you all so much for joining us today. COEH hosts occupational health and safety webinars the first Wednesday of every month from 12 p.m. to 1 p.m. Pacific. We'll be taking a brief break in January, but the 2020 webinar series will begin in February. We're also excited to announce the launch of an industrial hygiene webinar series in cooperation with NIOSH education and research centers around the country. That'll take place the second Tuesday of every month. This new industrial hygiene series is going to be in addition to our NIOSH ERC ergonomics webinar series, which takes place the third Wednesday of every month. Webinars galore. Thank you again so much for checking out this webinar today. You can find out more on our website at coeh.berkeley.edu. And a special thank you to Dr. Harrison for this presentation. I hope you all have a wonderful evening. Bye-bye.